Having talked about the different varieties of strokes, we know that basically we are dealing with these two major varieties. One of it is the ischemic kind of strokes, and on the other hand, we have the intracranial hemorrhages, or which is also termed as the hemorrhagic variety of strokes that we're going to discuss on today. So usually when you'll be working as the physicians and clinicians, and even in the emergency departments, you would come across these variety of patients who would come up to you, usually with a history of head trauma after a road traffic accident, and they would be suffering from an increased intracranial pressure. On investigations, when you'd be carrying out the radiological examination, you'd be noting down in the CT scans and in the MRIs, all of these radiological techniques are basically going to highlight the fact that this particular patient is suffering from some sort of an intracranial hemorrhage out there. So usually the most commonest areas that are being suffering from these intracranial hemorrhages are the basal nuclei, we have the thalamus, then we have the hypothalamus, the brainstem areas, the cerebral hemispheres. All of these areas are most prone to the development and where these intracranial hemorrhages can accumulate further on. What is the most important outcome? Obviously, it is going to increase the intracranial pressure, and that in turn is going to damage the brain cell. So this is the most important mechanism and the underlying pathophysiological mechanism out there. Moreover, we also come across these patients who are being they're being diagnosed with hypertension, and after that, they usually come across this cerebrovascular accident after that. They develop these intracranial hemorrhages in all of these areas. The microvasculature is basically damaged in these patients, and you usually come across these patients. There are multiple etiological factors that may also contribute towards the development of these intracranial hemorrhages, ranging from coagulopathies, it can be the use of drugs, even it can be some brain tumors that can lead to the development of these intracranial hemorrhages that we'd be discussing over here in this particular lecture. So moving on, we'd be discussing the most common types, or you can also define it as the most common sites for the development of these intracranial hemorrhages. Majorly, we have these three varieties, that is, we all know the protective layers of the brain. Mainly, we have the dura mater, then we have the pia mater, that is providing the protective covering to the brain, and after that, we have the arachnoid mater. So whenever there is a bleed that occurs in the cerebrovasculature, that is going to accumulate either in the dura mater, or it can even accumulate between the pia mater and the arachnoid mater. So these are the most commonest sites that we must know. Working as an emergency medical officer, you must know how to deal with these patients. Whenever you would come across these patients of intracranial hemorrhages, you must know that the most important thing that you have to cater for is to lower down the blood pressure levels in these patients, and specifically the systolic blood pressures. Mainly, the target is to lower down the systolic blood pressures to 140 millimeters of mercury, or even we can target for systolic blood pressures that are even lower than 140 millimeters of mercury. So we have basically conducted a lot of trials, and out of them we have the most notorious, which is basically the Interact-2 trial that was carried out in the United States of America on a lot of patients, and that basically emphasized on this fact that it is usually beneficial to lower down the systolic blood pressure to 140 millimeters of mercury. Now, what are the different kinds of drugs that we'd be using to lower down these systolic blood pressures? We can opt for nicardipine, we can opt for asmolol, then we have a variety of drugs. For instance, we have labetalol. One thing that is common with all of these drugs is that they are the non-vasodilating blood pressure lowering drugs. This is the most important thing that you have to note down, and that is basically the most significant thing over here. Now, again, basically, we want to provide protection to the patient from an ultimate shock that can arise in such patients. So we are not going to use, or we can have a contraindication for the use of the vasodilating drugs that can be used for lowering the blood pressure in these patients. Again, if you're going to carry out the investigations, obviously, you're going to take the history in detail. You're going to take a corroborative history from the friends, from the relatives, from the people who brought the patient to the emergency department or to your outpatient department, and you dealt in with these patients. A detailed corroborative history is again very important over here. Highlighting the main etiological factors. Mainly, we're going to write down the history of presenting complaints over here. The episode, the onset, you're going to write it down in detail, whether it was an acute onset or whether it was a chronic onset of the unconsciousness, or usually the major clinical manifestation over here is of seizures. So sometimes even patients who are suffering from intracranial hemorrhages would report to you with an episode of seizures that they recently had. So whatever the presenting complaint is, you're going to note down the onset. The episode is going to be written down in detail. You're going to document that episode in detail out there, highlighting the major factors and noting down whether it was a tonic-clonic seizures or either it was a myoclonic seizure. Again, it can be even a patient who is suffering from absence seizures out there. So you're going to write down the type of seizures that the patient had. Again, if it was just an episode of unconsciousness, you're going to write down whether the patient had any history of urinary incontinence, either tongue bite, and again, you're going to document it down in detail in your history of presenting complaints out there. Again, drug history is very important over here, and you're going to note down whether the patient is on any kind of recreational drug abuse. Drugs of abuse, specifically cocaine and amphetamine, are very notorious out there, and usually young patients suffer from intracranial hemorrhages, and they would usually report to you, and when you take the history in detail, that is going to highlight the fact that they are on some sort of recreational drugs. Again, the radiological evidence is very important. Any recent history, any surgical interventions that have been carried out on the patient, any drug history, any pharmacological drug history is going to be noted down over here. Again, you're going to highlight the facts over here of any family history, any related family history that the patient had. A lot of patients suffering from coagulopathies that are usually genetic in origin usually present to you in the outpatient departments with these histories. And when they are investigated, it is noted down or it is diagnosed in such cases that these patients are suffering from the intracranial hemorrhages. So again, it's very important to note down the family history in these patients. Brain tumors, for instance, lung carcinomas, we have renal cell carcinomas, thyroid carcinomas, usually metastasize towards the brain, and they can even present with numerous intracranial hemorrhages out there. So we'd be focusing on these three types, mainly the epidural hematomas. And it can be, as I was already emphasizing on the fact that we have these three protective layers, mainly the epidura, then we have the pia mater, we have the arachnoid mater. So if we have the accumulation of blood that is outside the dura mater, we're going to term it as the epidural hematoma. It is one of the commonest presentation after trauma, even after the road traffic accidents or blunt trauma. Patients usually present with this kind of an epidural hematoma. So it can be even after the coup injuries, that is a direct contact that is a direct contact of the cerebral vasculature with a blunt object or even a sharp object, and developing this kind of an epidural hematoma subsequently in these patients. Again, we have the intracerebral hematomas. So whenever there is the microvasculature that is damaged, it can be the anterior cerebral artery. We can have the middle cerebral artery. And on the other hand, we have the posterior cerebral vasculature that can be damaged, mainly the lobar accumulation of the hematoma in these areas. Either it is the frontal areas, the temporal areas, the parietal areas, or even it can be the occipital areas. And depending upon that fact, the patient is going to suffer from a particular set of clinical features out there. So we're going to focus on the location of the intracerebral hematoma. It can be the basal nuclei, mainly the putamen, the globus pallidus. All of these are affected, and the patient usually suffers from the contralateral paresis in such cases. So whatever the case is, after we carry out these radiological investigations in these patients, we're going to highlight the fact that what is the exact location of the collection of this blood, that is the intracerebral hematoma, and that is again going to make it easier for you as a clinician just to highlight the major clinical features that the patient is going to suffer from. Now we're going to focus on the fact that it can be even another kind which is known as the subdural hematomas out there. So whenever the accumulation of the blood takes place subjacent to the dura mater and below it, between the arachnoid mater, it is going to collect, and we're going to term it as the subdural hematomas out there. So again, it's very important to localize the fact that what is the exact location out there, because it is going to compress the structures that are lying underneath it. So again, it's very important to focus on the fact that whatever lobe is affected, either it is the frontal lobe, usually the patients in which the frontal lobe is affected present to you with the arm weaknesses. Then we can have even patients who are suffering from the parietal lobe, which is affected. Primarily, patients who are suffering from a parietal lobe injury present to you with a hemisensory loss. Then we have the temporal lobe, which is affected in a lot of patients and usually present to you with the auditory evaluations. Sometimes there is aphasias, the patient is suffering from sorts of deliriums and ataxias, that is the loss of coordination is very important over here. Then we have the occipital lobe. Usually patients who are subjected to this kind of an occipital lobe injury, they usually present to you with hemianopia, that is half of the visual field is affected in these particular patients. Even we have patients who are suffering from quadrantanopia, in which one of the quadrant of the visual field is affected particularly. So these are the different clinical pictures that you'd usually come across depending upon the lobar injury that the patient is usually suffering from. Now, again, within 30 to 90 minutes of this trial of injury that starts off, this cascade of events that starts after the accumulation of the blood, within 24 to 48 hours, the patients usually settle down. The hemorrhage usually stops, except for the patients who are on some sort of coagulopathy treatment. For instance, you would usually come across patients who had a recent MI, that is the myocardial infarction, and they're usually put on a treatment of coagulopathy. And after that, if there is an episode of intracranial hemorrhage, it can lead to a massive collection of blood accumulation, either in the form of subdural hematomas or either in the form of intracerebral hemorrhages. So it's again very important to be very cautious when you have these patients who are on a treatment of coagulopathies and you are basically treating to resolve these intracranial hemorrhages in such patients. Again, after almost within 48 hours, the macrophages are going to start off with their phagocytic activity, and that is going to resolve some of the minute accumulation of the blood, that is the intracerebral hemorrhages that can take place. And that is also going to again result in the transient attacks. The patient may suffer from some of the symptoms, and that are going to resolve after these resolutions of the small hemorrhages due to the macrophage activity, the phagocytic activity that takes place or that starts to take place within 48 hours of the onset of the symptoms. So this is the underlying mechanism, the defensive mechanism that is present in a person, and that can take place accordingly, and that usually results in transient attacks in individuals. So again, it's very important if the patient had any recent transient attacks and then he had presented to you in the outpatient departments. So having done with these kinds of the intracranial hemorrhages, we must know that there are a lot of factors that contribute towards the development of these intracranial hemorrhages. We must know that through the rigorous investigations, either these are the radiological investigations, such as the CT scans or the MRIs that can be done in such patients. We can even opt for conducting the prothrombin tests, that is the APTTs, the PTTs, that can be done just to note down the INRs in these patients. Specifically, the patients who are on a treatment for coagulopathies, they are at a high risk for the development of these intracranial hemorrhages, and so that is going to be noted down for such particular patients. Having done that, basically a lot of causative factors, for instance, head trauma, patients who present to you with a particular kind of a head trauma, may it be a blunt trauma, road traffic accidents, all of these are very important, and they usually present to you with massive intracranial hemorrhages. We have the coup injuries, that is when the head basically comes in direct contact with that particular blunt object. We must note down whether there is an injury at the site of contact. On the other hand, we have the contact injuries, that is the injuries that are occurring due to the decelerating or the accelerating effects. So even injuries can occur far away, distantly from the site of contact, and they're basically known as the contact injuries. Even the coup and the contact injuries, both of them can result in the intracranial hemorrhages in these patients. Patients who are diagnosed with hypertension usually present to you with such intracranial hemorrhages due to the rupture of blood vessels, may it be the middle cerebral artery. Usually the most common artery which is involved in the hemorrhages is the middle cerebral artery. So the typical areas that are involved in such kind of an injury are the basal ganglia, the thalamus, the hypothalamus, and the brainstem areas are usually more prone to the development of the accumulation of such episodes. Then we have the transformation of the prior ischemic infarction. It is again going to be noted down if the patient had previous attacks of transient symptomatologies after minute hemorrhages. We're going to note down even the past history. Past surgical interventions are going to be noted down for such particular patients. Then we have the metastatic brain tumors, and we're going to note down whether the patient may be suffering from some sort of a metastatic brain tumor. Now, what are the kind of tumors that can metastasize more commonly to the brain? It can be the lung carcinomas, we have the renal cell carcinomas, the thyroid carcinomas, and sometimes we have the melanomas that can even metastasize to be the brain tumors, and usually they present to you as the whenever you carry out the CTs and MRIs, you're going to diagnose these patients to be suffering from some sort of a brain tumor. Then we have the coagulopathies, and patients who are suffering from these genetic conditions may be more prone to the development of these intracranial hemorrhages. So it's again going to be very important to have the lab investigations done. All of the baseline investigations, including the erythrocyte sedimentation rate. We're going to focus on the prothrombin, the APTTs. They're going to be noted down, and any abnormalities are going to be documented accordingly. Then, of course, a lot of recreational drugs, for example, cocaine and amphetamine are very important over here. The exact mechanism is unknown, but the proposed mechanism is basically it can be the sympathomimetic activity that is enhanced by such kind of recreational drugs basically results in hypertension, and it can be an extreme episode of an extreme hypertensive episodes that are noted down in these individuals, and they are going to result in this rupture of the cerebral vasculature, resulting in the accumulation of blood inside the cerebral vasculature, inside the lobars, or inside the ventricles as well. Then a lot of genetic and a lot of congenital conditions. For instance, we have the AV malformations that are again quite prone to the development of these intracranial hemorrhages due to the ruptures. The significant and the consequent ruptures that can take place in these AV malformations make the patient more prone. Again, it is usually an accidental diagnosis. When you carry out the CT scans or the MRIs in these patients, you would note down that these patients have the accidental diagnosis of AV malformations, or even another very important factor that contributes towards this development, another congenital condition, which is the aneurysms, that is the congenital dilatation at any specific point in the cerebral vasculature is known as the aneurysm, and it's again prone to rupture. So it can be one of the causative factors towards the intracranial hemorrhages. Both of these conditions, AV malformations and aneurysms, are usually the accidental findings on CT scans and MRIs. Then we have the patients who are suffering from amyloid angiopathies. So the deposition of amyloid in the walls of the vasculature, either it is the cerebral vasculature, it is going to weaken the walls and make it more prone to the intracranial hemorrhages or these cerebrovascular accidents. Then we have the cavernous angiomas. One of the tumorous conditions, we have the dural AV fistulas, again, one of the conditions making the patient prone, one of the most important risk factors out there can be the capillary telangiectasias. Now, you can just overview through this that there are a lot of genetic conditions, and we have a range of acquired conditions that are making out the list of risk factors, making the person prone to the development of intracranial hemorrhages out there. So it's again very important that you do the detailed investigations and note down any malformations, note down any coagulopathies or any histories of intake of recreational drugs in these patients. Now, moving on to the diagnosis in such cases, it's again very important that you would start off with the baseline investigations in these patients. We'd be starting off with the CBCs, the white cell count, the erythrocyte sedimentation rate, APTT, PTTs, and obviously, having done these preliminary investigations, we're going to move on to the radiological investigations. They are the highlights for the diagnosis. Having done the CT scans, the MRIs, they are making the diagnosis much more easier in these patients. We have the non-contrast CT imagings. Specifically, as you can just have a look at this phenomena, that we have a kind of a subdural hematoma over here that is pointed out by this arrow. And whenever you carry out the CT scans and MRIs, it's going to make it more easier for you to note down whether there was an intracranial bleed. We must be knowing these facts that it can be an intracranial bleed. Then we can have the bleed areas can be surrounding the brainstem, and even in a lot of cases, we have the spinal cord that is involved. So all of these areas are prone to the accumulation of blood. CT scans and MRIs are done whenever patients presents to you with hemiparesis on one side, ataxia, loss of coordination, aphasias, pains that are not really responding to the normal painkillers, that are making you suspicious towards the fact that this particular patient might be suffering from some sort of an intracranial hemorrhages. And that would be the patient in which you're going to carry out these radiological investigations, just to rule out the fact that whether this patient is suffering from an ischemic variety or either it is a hemorrhagic variety of stroke that this patient is suffering from. So this is how you're going to carry out your investigations, and obviously once you have these patients in your emergency departments, you must know how to basically go through these patients, how to start off managing these patients. If you suspect any intracranial hemorrhages in a patient, the brain attack activation has started off. A single alpha page stroke team is basically out there to help you out. Then you have obviously the CT technicians that are an important part of the management team. We have the neuro ICU, that is the intensive care unit nursing staff that is available at your hand, and all of them are basically a part of the management team. They're important for the initial evaluation. And with the help of the teamwork, you're going to initially evaluate these patients. As any emergency case, you're going to stabilize the patient by securing the airway, breathing, and circulation. That is, check and secure the ABC. This would be the preliminary step in these patients. Moving on, we'll infuse the peripheral IV placements and draw the blood for the coagulopathies. We'll have the complete blood count picture for these patients, and also the CMP criteria has to be fulfilled. Oxygen supplementation, whenever I say I'm stabilizing the patient, maintaining the airway, that means the tracheal intubation is very important. Then the breathing is stabilized by the oxygen supplementation to keep oxygen saturation more than 92%. Then the continued pulse oximetry and the cardiac monitoring is also very significantly done. Having done that, when you have stabilized the patient, you have a stabilized airway, After you have the intubation done, you have the oxygen monitoring being done, the breathing is stabilized, the circulation is stabilized, you have stabilized the blood pressure in these particular patients. You're going to start off with the physical examination. Starting off with the general physical examination and moving on to the systemic neurological examination. Then you're going to carry out the non-contrast enhanced computerized tomography for these patients. CT evaluation of the intracranial hemorrhages. After that, you're going to start off with the drug therapy, specifically the non-vasodilating drugs, for instance, the labetalol, 10 milligrams per hydroxyline, that is usually given IV to keep the systolic blood pressure more than 140 millimeters of mercury. It is very important to maintain the blood pressure range more than 140 millimeters of mercury in these patients. Then obviously you're going to start off with nicardipine. You usually infuse nicardipine at 5 to 15 milligrams per hour as needed in these patients. This is a step-by-step approach to these patients. The emergent reversal of coagulopathies is very important. If you find out that the patient is on some sort of a pharmacological drug, which was a part of the coagulopathy treatment, you're going to stop that drug right away. Mannitol, that is usually given 0.5 to 1 gram IV, bolus or hypertonic saline for mass effect or the herniation effect. Usually lumbar puncture is prohibited for such patients. Either surgical indications are there. You have to consult the neurosurgeon for such surgical consultations. Ventriculostomy is one of the options out there. And if it is a patient of hydrocephalus, you're going to note it down and then subject it for some sort of surgical intervention. Craniotomy for large cerebellar or temporal intracranial hemorrhages. And if there are no surgical indications, you have to admit the patient to the intensive care unit and just have the symptomatic treatment being performed for such patients. An order for a set of intracranial hemorrhage patient and then manage these patients symptomatically accordingly. Now we have the patients of intracerebral hemorrhages. The most common site, as I was already focusing on the fact, is the thalamus. We have the basal ganglia, specifically the putamen, the globus pallidus. And usually these patients would present to you with the hemiparesis on a particular site. The causative factors are the hypertension. We have coagulopathies, and then the patient's sympathomimetic drugs. They can be the recreational drugs such as amphetamines and cocaine. So we have the condition of cerebral amyloid angiopathies that results in the deposition of amyloid in the cerebral vasculature out there. The particular clinical manifestations in particular kind of syndromes or the particular areas when they're affected is, in a general condition, the patient would have an abrupt onset of focal neurological deficit in particular. Then seizures are a very uncommon variety of presentations out there. There would be a diminishing level of unconsciousness noted down, the signs of increased intracranial pressure, such as headache and vomiting would be there. Then we'd have the contralateral hemiparesis. If the thalamus is being affected due to the hemorrhages, the patient would have the contralateral hemiplegia or hemiparesis. Sensory deficit is going to be present in the patient. The patient, if the Broca's area or the Wernicke's area is affected, that the patient may be having the aphasias. Particularly, the patient can have constructional apraxia or mutism. Ocular disturbances by virtue of extension. Particularly if the pontine hemorrhages occur, the patient may be in a deep coma with quadriplegia. The word quadriplegia is basically signifying the fact that all four limbs are affected in these particular patients. Decerebrate rigidity, when you'd be carrying out the reflexes in these patients, you would find out that there is a rigidity that is noted down in these particular patients. The patients may be suffering from pinpoint pupils, doll's head, or oculocephalic maneuvers are noted down. Whenever you are rotating the head, it is going to go sideways along with the movements. Then there is the hyperapnea. That is increased in the respiratory rate. Severe hypertension and hyperhidrosis is noted down. The particular cerebral hemorrhages are seen, and we have the occipital headaches that are quite common in such cases. The patients would present with episodes of vomiting and vertigo, and particularly the ataxia of gait. The uncoordinated gait is a specific sign. Forced deviation of eyes to the opposite sides is seen. And then we have a particular sign known as the ipsilateral sixth nerve palsy. Blepharospasm is noted down. Ocular bobbing phenomena, that is basically the protrusion of the eyelids. Sixth nerve is usually involved in this kind of an ocular bobbing reflex. We have a skew deviation. Skew deviation is usually a nystagmus that is noted down on a downward gaze. Then we have dysarthria, that is difficulty in speech, and dysphagia, that is difficulty in swallowing. It is one of the key factors out there. Stupor and coma is one of the important factors. And then we have finally the compression or the obstructive hydrocephalus, even noted down in such kind of cerebral hemorrhages. Noting down particular lobar areas can be affected whenever we have these particular lobar connections along with that. The clinical manifestations particularly associated with hypertensive intracerebral hemorrhages are decerebrate rigidity, coma. It can be a deep coma. Dysarthria, which is known as slurred speech, is noted down in these patients. The patients can be a diagnosed case of hypertension, or even it can be a newly diagnosed case. Signs of upper brainstem compression, dilated and fixed ipsilateral pupils, also known as the pinpoint pupils, are seen in such patients, and edema is seen in the adjacent brain tissue. Eyes usually deviate from the side of hemiparesis in such patients who usually present to you after an attack of hypertension. Face sags on one side over 5 to 30 minutes, and there are deep, irregular, or intermittent respiration. There's going to be an irregular respiration that is noted down for such patients. Arms and leg, they gradually weaken out for such patients. Then moving on, we have the lobar hemorrhages. Particularly, we must note down that we have these important lobes noted down as the frontal lobe. Then we have the temporal lobe, particularly we have the parietal, and then we have the occipital lobe. For instance, if the occipital lobe is affected, usually the patient presents to you with hemianopia. Then we have the frontal lobe that usually present to you with ataxia and loss of consciousness. Patients who are suffering from a temporal lobe injury usually presents with aphasias, and it can be even a difficulty in speech that is known as dysarthria, which is noted down in these temporal lobe injuries particularly. Other causes of intracerebral hemorrhages, they include the cerebral amyloid angiopathies. We have the cocaine and methamphetamine, that is the recreational drugs which result in these cerebral hemorrhages, head injuries, road traffic accidents. We have patients of intracranial hemorrhages, brain tumors, specifically the metastasizing brain tumors from the other areas of, for instance, the renal cell carcinomas and the thyroidal carcinomas can metastasize to the brain. We can have the hypertensive encephalopathies, the primary intraventricular hemorrhages, sepsis. We have the Moya disease. So it's again one of the genetic conditions that can occur. It's basically resulting in the common carotid artery blockage, and there are a lot of collaterals that develop towards the brain. Usually patients of this particular congenital disease presents to you with numerous intracranial hemorrhages. It is one of the conditions that can develop with the passage of time. Then we have the spinal cord hemorrhages, and patients with these spinal cord hemorrhages presents to you with headache, vertigo, vomiting. AV malformations is one of the causative factors over here, cavernous malformations, and then we have the metastatic tumors. The epidural spinal hemorrhages, they can even present to you. And the usually causative factors or the risk factors are the syndromes of the spinal cords or the nerve root compressions over here. The laboratory evaluations over here are the routine blood tests that can be carried out for such patients. We have the platelet counts, including the APTTs, and we can even move on for the INR examinations, the prothrombin time, the PTTTs, and the INRs. They usually enhance the factor whether the patient is suffering from some sort of a coagulopathy or not. So these are the baseline investigations that you'd be carrying out. The imaging evaluations, particularly the CT scans and MRIs, are very important and very critical. They usually enhance the factors, particularly the sites of impacts or the lobar effects that are seen on the CT scans and the MRIs are very important, and you have to focus on these facts and highlight the important areas that are being damaged. The ICH scoring is basically how you manage these patients in the emergency departments. The age is a very important factor out there. Usually there is no score for a patient who is less than 80 years, and patients who are above 80 years basically score a single point. Then we have the hematoma volume. If it is less than 30 cubic centimeters, it is usually a 0 that scores for it, and if it is more than 30, we score it as a single point. Then is the interventricular hemorrhage, which can be present. If it is a yes, it is going to give a single point. If it's the infratentorial origin of hemorrhage, if it's a yes, it is going to be a single point. The Glasgow Coma scale, the level of consciousness is very important. If it's between 13 to 15, it's a 0. If it's 5 to 12, it's a single point. If it's 3 to 4, then there are 2 points for such a Glasgow Coma scale. Now, how does it affect the management, and how does it affect the outcomes of such intracranial hemorrhage patients? If the score is a 0, the mortality rate at 30 days is 0, and the patient is going to walk independently at 12 months. The chances for that are almost 70%. If the score is 1, then the percentage mortality would be 13%, and the percentage chances to get the patient mobile in a period of 1 year is almost 60%. Then if the score is 2, we have the percentage mortality it rises up to 26%. And the chances for the patient to get mobile at a period of 12 months is almost 33%. If the score is 3, we have 72% percentage for the mortality, and the chances for the patient to walk independently, to get mobile at 12 months time period is almost 13%. So the chances become quite low. As the score rises, the chances for the patient's mortality, they rise up, and the chances for him to get mobile, they lower down. A score of 4 basically suggests that 97% mortality is noted down, and there are almost 3% chances for the patient to get mobile at a time period of 12 months. For a score of 5, the percentage mortality is 100%, and the chances for the patient to get mobile is almost 8%. So this is how the final outcomes and the prognosis in these patients is going to change along with the ICH scoring that we're going to note down in the emergency department. The acute management for such patients would be a rapid correction of coagulopathy, infuse the prothrombin complex concentrates with vitamin K, And the fresh frozen plasma is given for such patients when the platelet count is less than 50,000 per microliters. The transfusion of fresh platelets is going to be arranged for these patients. Then obviously, we can even transfuse the recombinant 7A factor, the evacuation of supratentorial hematomas, the surgical interventions, if it is indicated and the supportive therapy is not going to respond quite well for such patients, then we're going to opt for the surgical management and the removal of such hematomas. Then again, if the cerebellar hemorrhages are almost 1 to 3 centimeters, we usually carefully go for an observational state for such patients. The signs of impaired consciousness are noted down, the progressive hydrocephalus is going to be noted down, and the precipitous respiratory failure. So we usually only stabilize the patient, that is, maintain the airway, breathing, and circulation, and just wait and watch for the patient. Again, if it is the cerebellar hemorrhages are more than 3 centimeters in their diameter, surgical evacuation is needed for such patients. So over here in this particular lecture, we just summarized the condition of intracranial hemorrhages. Whenever you receive such patients, you should be well versed with this kind of a condition and what are the different management options and treatment options out there which you can opt for and manage these patients accordingly. So that is the end of this lecture. Thank you for watching sqadia.com.